Ladies and gentlemen, esteemed guests and participants, welcome to our session on handling MSA symptoms, neurogenic orthostatic hypotension, dysphagia, and sleeping issues. Today, we are privileged to hear from three distinguished experts who will share their insights on common multiple system atrophy symptoms. Our first speaker, Dr. Italo Biagioni, specializes in autonomic disorders. Dr. Biagioni will discuss the impact of neurogenic orthostatic hypotension and cover effective strategies to manage this challenging MSA symptom. Next, we will hear from speech pathologist Laura Purcell-Verdun. She will discuss the impact of dysphagia or swallowing difficulties and provide practical approaches to enhance your quality of life. Our final speaker for today is neurologist Dr. Mitchell Miglis, a specialist in sleep disorders. Dr. Miglis will guide us through sleeping issues in the context of MSA and offer information on addressing these challenges to promote restful and restorative sleep. Together, these three experts bring a wealth of knowledge, experience, and compassion to our session. We are grateful for their dedication to advancing our understanding of MSA symptoms. Without further ado, let us warmly welcome Dr. Italo Biagioni, Laura Purcell-Verdun, and Dr. Mitchell Miglis to share their expertise.
Hello, I'm Dr. Biagioni from the Autonomic Dysfunction Center. Most patients call me Dr. B because my name is a little bit strange. So today I would like to review the ABCs of OH, orthostatic hypotension, and this will be a little bit different because I'm going to focus on how you can take control of your treatment of OH. So whenever in patients that have autonomic impairment, if they stand up, their blood pressure tends to drop, and that impairs their ability to stand up, and it causes significant disability and impairs quality of life. But most importantly, it also increases the risk of fainting and falls. So it is very important to treat your OH, and I would argue that the patient should have an active role in their own treatment. So it's important to understand why does OH occur, because I will teach you what you can do about it, to recognize the warning symptoms that comes with OH, the aggravating factors, and then with this knowledge, you can play an active role in your own treatment. So why does OH occur? So when we stand up just by gravity, there's pooling of blood in the abdomen of about 24 ounces. And that's blood that doesn't go back to the heart and doesn't go back to the brain. But as soon as that happens, normally the autonomic or noradrenaline system will kick in and squeeze that blood back to the heart and to the brain. If this system is not working, then you're going to have less blood going up to the brain, and you will feel lightheaded. And if you don't sit right away, you can faint. So it is important to recognize the symptoms associated with this low blood pressure, because I would argue that the most important goal of the treatment is to prevent falls and avoid fainting. So as soon as you get these symptoms, you should sit or lie down. Don't try to fight them because you are going to lose. And you just need one bad fall to end up in the hospital with a broken hip. And believe me, you do not want that. And there's actually studies showing that patients that are unable to recognize the symptoms are at increased risk of falls. So it is important, therefore, to understand what those symptoms are. And the classical symptoms of low blood pressure to the brain are lightheadedness, dizziness, and dimming of vision. There's other symptoms like pain in the neck and the shoulders, what we call coat hanger pain, that can also tell you that the amount of blood to your brain is low. And patients sometimes feel many other symptoms like tiredness or not able to concentrate. The bottom line is that whatever symptoms that you identify that get worse when you stand up and improve when you sit down, those are the symptoms that you need to pay special attention and prevent fainting. It's also important to recognize factors that can aggravate OH, because OH is not fixed throughout the day, but changes with very different conditions. For example, typically, OH will be worse early in the morning. And the reason is that during the night, your blood pressure tends to be high. That makes your kidney produce more urine. On an average night, our average patients loses 4 pounds of weight in one night because of all the volume that they lose. And you might experience this yourself, having to get up to the bathroom during the night. That means that you've lost all that volume, and early in the morning, your volume depleted, you're dehydrated, and therefore the OH will be worse. So what can you do about this? Well, first, don't expect to jump out of bed first thing in the morning. You need to take it easy. The other thing that can help is have by your bedside a bottle of water, 16 ounces, and drink it all at once. That will help your blood pressure, and we will discuss that more in a minute. And take your blood pressure medications as soon as you wake up. Keep in mind, however, that most medications take at least 30 minutes to kick in, so you might need to wait that long before you're up and around. Another problem that worsens low blood pressure on standing is meals. Remember, I told you that when we stand up, there's pooling of blood in the abdomen. Well, with meals, there's the same phenomena. There's pooling of blood in the gut just for digestion, and that will make the standing blood pressure lower. And blood pressure can drop as much as 30, 40 points, or even more. It happens rather quickly. It's worse at around 30 minutes, and it lasts about 1 hour. So you need to be careful. Some patients might not have this problem as much as others, but something that you need to be careful. And it is worse if you're eating a lot of sugars or carbohydrates. So what can you do about this? Well, you can eat smaller and more frequent meals. It's okay to take a nap after a meal. And you can prevent this drop in blood pressure if you drink coffee with meals, or if you take a medication called acarbose that delays the absorption of sugars and therefore prevents that fall in blood pressure. Another thing that will make the low blood pressure worse if you stand motionless, for example, like waiting in line. And that's because normally the leg muscles pump that blood back to the heart, and if you're standing without moving, that will make it worse. So what can you do? Well, you should avoid standing still. You can cross your legs or move around, again, to activate those leg muscles to pump the blood back to the heart. Heat will also worsen the low blood pressure on standing. And the reason is that it will vasodilate the skin. And you might think that is not important, but the surface of the skin is so large that every bit counts, and that can be enough to make the low blood pressure worse. Plus, our patients are unable to sweat and to dissipate heat, so they are at an increased risk of heat stroke. So what can you do about this? Well, you can avoid hot showers, which will typically make things worse. You can drink a big glass of water right before going to the shower and avoid being out in the heat. And this is recognized even in normal people, very fit people, like soldiers standing on attention on a hot day will start fainting. So much so that Kipling famously coined the phrase, only mad dogs and Englishmen go out in the midday sun. Because, the English were very proper and they kept all the regalia with wools and everything in the hot days of India, and they start fainting. So once you understand the disease, recognize the warning symptoms and the aggravating factors, you need to play an active role in your own treatment. So there's a lot of things you can do on your own without medications. For example, we've mentioned this, take it easy early in the morning, don't try to jump out of bed. Drinking 16 ounces of water can have a dramatic effect, increasing your blood pressure on standing. And this is an example of blood pressure taken over time. And you can see this dramatic increase in systolic blood pressure just by drinking 16 ounces of water. It kicks in very quickly. It peaks at about 30 minutes. It doesn't last too long, but it can help you in a bind to overcome acute symptoms of lightheadedness. Temperature doesn't make a difference. It can be cold. It doesn't make a difference. And the interesting thing is, but it has to be pure water, cannot be Gatorade. And we learned this from a patient, actually, who told us that, he felt so much better with after drinking water. And my former mentor, David Robertson, looked at this and found this dramatic effect. So there's a lot of things we always learn from our patients, and this is one of them. The other thing you can do on your own is wear an abdominal binder. Remember, I told you that when we stand up, there's pooling of blood in the abdomen. Well, you can squeeze that blood by using an abdominal binder as tight as you can tolerate it, but you only need to tighten it up right before standing. You can wear it loose while you're seated. It can be as effective as midodrine. We've shown that. And we like this design because, again, there's an extra belt that you can use to tighten, is the Copper Fit Advanced Back Pro. Copper has nothing to do with it, it's just a gimmick. And the Advanced Pro is so they can charge you $5 more for the name, but it's only like $20 or $30 in Amazon. So it's a good investment. Some patients benefit a lot more than others, but certainly worth trying. So it's also important that you manage your own medications. And this sounds like an unusual thing for a doctor to say, because we're used to tell patients how they should be taking their medications. But I will explain that it's important that you take it when you need them and not when you don't need them. And I'll explain that in a minute. So the goal of using medications to increase blood pressure is not to normalize blood pressure. And your blood pressure will always drop when you stand up. The goal is to improve your standing blood pressure, but only as necessary to prevent symptoms. There's a magic number that is different from patient to patient. In some patients, it can be systolic of 80, others 100, above which you don't have any symptoms anymore. And therefore, we only need to increase blood pressure to that level, and we don't need to increase it more. And it makes no sense and is counterproductive to take medications that increase your blood pressure if you're going to lie down. it doesn't help you at all. These medications are only meant to help you stand up, and it really makes no sense to take it unless you're going to be trying to be up and around. So likewise, you need to realize that it takes about 30 to 45 minutes before the medication kicks in, and you need to plan ahead and take your medications at least 30 minutes before being up and around. And likewise, most of our patients improve on their own in the afternoons. So if you're not going to be active, you can skip the last dose of the day. So I think it's also important for patients to learn how to measure your blood pressure. For example, you can diagnose whether your meals lowers blood pressure in your particular case or not if you check your seated blood pressure in the same position before and 30 minutes after a high carbohydrate meal, for example, a breakfast with pancakes. That will tell you whether your blood pressure is dropping with meals, and you can take medications for that, and you can be more careful. It also helps physicians figure out how well your medications are working. If, for example, you measure your seated and standing blood pressure and heart rate before and 1 hour after your dose of medications, you will expect that your standing blood pressure will improve after you take your medications. And if it doesn't, then we need to try something else. But that is information that would be very useful to have. Likewise, some patients have high blood pressure lying down, and you can diagnose that yourself by checking your blood pressure at bedtime when you're lying down before going to sleep to see if it's high, because if it is, we can give medications at bedtime to lower blood pressure only during the night. So to summarize, I think it's important for patients to be aware what the symptoms are of low blood pressure when they stand up so that they can prevent falls and fainting. That is as important or more than anything else we can do to treat this disease. It's also important to recognize factors that will make OH worse so you can avoid them or manage them. And like I said, early morning, heat, standing still, meals, all these things can make it worse. How worse varies from patient to patient, and it's important that you understand which factors are making things worse for you. And it might not be evident at first until you start thinking about it. It's also important to learn how to check your blood pressure so you can manage your OH, and to time your medications for maximal effect. And again, like I said, keep in mind that it takes 30 minutes for medications to kick in, so you need to think ahead, take it before you're going to be up and around, and there's really no reason to take it if you're planning to be lying down. It's counterproductive. And finally, I think it's important that patients feel like that they are taking control of their orthostatic hypotension. So with that, I will stop. Happy to answer any question. I hope this has been helpful, and you can get more information if you Google Autonomic Dysfunction Center, and you will find our site there.
Good day. It's a pleasure to be with you today. Thank you to the MSA Coalition for the invitation. I'm Laura Verdun. I'm a speech pathologist here in Washington, D.C. Today we're talking about changes in swallowing associated with multiple system atrophy. Research has shown, as well as our clinical experience, that disorders of swallowing and MSA as compared with Parkinson's disease, develop early, are more prevalent and more disabling, which brings us to this conversation. What are my goals? Well, my goals as a speech pathologist ultimately are to align with your goals. I work to assist in supporting the clinical diagnosis. We do find that there are features of speech that are more consistent with MSA versus Parkinson's disease, for example. We want to provide proactive as well as symptomatic treatment. We're trying to get ahead of the problems. For that to happen, we need more accurate, more timely clinical diagnosis. We're looking to maintain skills, establishing strategies and exercises earlier on in the course of the disease progression, education, such as today, as well as support in helping you to define your priorities moving forward in regards to communication and swallowing. Today, our conversation is about swallowing. The index of suspicion for difficulty swallowing in persons with MSA should be high. Disordered swallowing is called dysphagia. Dysphagia can have numerous symptoms and numerous different features. We have found that in MSA that there are disruptions to reaction time of the nerves and the muscles, efficiency, meaning how well the muscles clear the foods and liquids through the mouth and throat, for example. We also have found that there are higher incidence rates of pneumonia in persons with more severe MSA, as well as persons with MSA-P, MSA Parkinsonian versus MSA-C cerebellar. In addition to swallowing, we also need to talk about coughing and breathing, because coughing and breathing are also integral to swallowing, as well as protecting the airway and the lungs. Disordered cough is called dysphagia. Studies have been done to look at cough in these movement disorders, as well as identify cough as a specific therapeutic target. I'll come back to that in a moment. Secondly, we know that in MSA, and the numbers are highly variable, from anywhere from 30 to 70% of persons may develop impaired movement of the muscles in the voice box, of the larynx, the vocal folds. It can actually be from paralysis, meaning the muscles not working at all, or just disturbed muscles or disturbed muscle movements which interfere with breathing, airway protection, and voice. What are some of the clinical signs that there may be a change in swallowing? Here's an exhaustive list. This is not specific to MSA, but I wanted to highlight a few that I think are particularly important. Changes in speech and voice. As the voice gets weaker, that can indicate that airway protection is not as strong as it used to be. Changes in precision, articulation of speech. Those are the same muscles that are manipulating foods and liquids. If they're weakening for speech, they can also be so for swallowing. Coughing more during meal times than at other times of the day. Meal times taking a longer period of time. Is it related to actually slow swallowing, or is it related to feeding, meaning taking foods and liquids from the plate, the table, to the mouth? It's worth trying to distinguish those. Impaired alertness at meal times. If you're not awake or have difficulty staying awake, that can be problematic and interfere with safety of swallowing. And then finally, I think one of the other more important ones is difficulty managing secretions, accumulation of mucus and saliva in the throat. Specific to MSA, some studies have been done and have highlighted a few things that are most consistent. One is related to posture. There's a tendency towards leaning forward, as well as what's called anterocollis, which is the head and neck moving forward. Holding the food or liquids in the mouth, it's not intentional, it just happens. It's usually a problem with difficulty getting the swallowing going. Accumulation of secretions in the throat. We talked about impaired movement of the vocal folds, and then subsequently changes in cough. There is something called silent aspiration. You would assume that if something goes down the wrong way, you would know it, or there would be some outward sign that that's the case. But There is something called silent aspiration, is when food or liquids or saliva, whatever, goes down the wrong way, which is towards the lungs instead of the swallowing passageway or the food tube towards the stomach. It doesn't mean that people aren't paying attention. It's just their body is not working as well as it used to. What are some of the things that contribute to aspiration pneumonia? You would assume anybody who has trouble swallowing is at risk, but it turns out trouble swallowing is not the biggest risk factor. Studies have shown that poor oral hygiene is the biggest risk factor. It's important that you maintain good oral hygiene as best as possible. It doesn't have to be anything fancy. Brushing teeth twice a day, keeping up with your dentist, things like that. Impaired cough. Limited mobility, meaning just getting up and moving around. The more you're able to get up and move around, and I realize that can be difficult, but the less mobility there is, the more likely things are to settle in the lungs. And then depending on others for mealtime assistance, either with drinking, with the fork or spoon, that always, not always, but that often increases the risk of a pneumonia. So we know there's a problem. What can be done about it? Observe at meal times. What seems to be most problematic? I am always, as a clinician, looking for patterns, not a one-off. You have trouble with something once, that doesn't concern me so much, but I'm looking for every meal or every dinner time, things like that, where there are repeated problems. Optimize posture. We're looking to position people upright as best as possible. I have this buttoned up sweater. So I could take the sweater and just position it over the back of the chair to help keep me upright and keep me secured to the chair so that I'm not leaning so far forward. Promoting alertness, or at least waiting till you're more alert in an effort to enhance safety. Clearing secretions out of the way, coughing them out of the way, wiping them out of the way, using a portable suction machine, which you can get as a piece of durable medical equipment. Ask your physician for a prescription for that. Controlling for rate of ingestion. It's never possible that we want to encourage going faster. It's always go slower, take your time. And then make a list of where the problems seem to lie. Keep track of notes. Bring those with you to your speech pathologist, your physician, so they can also identify what needs to happen next. Whatever problems you identify, are there things you can adjust on your own? So for example, boneless, skinless chicken breast is always going to be harder to swallow than dark meat. A plain chicken breast by itself is also always going to be harder to swallow than when it's in a casserole. Use of condiments, gravies, sauces do provide some extra calories, but they actually just provide extra lubrication to promote manipulation and ease of swallowing. I encourage you to talk to your neurologist, nurse practitioner, primary care physician, speech pathologist to provide guidance and instructions on how to perform the Heimlich maneuver. People often ask about thickeners. Thickeners have been around now for decades. They come in the form of a powder or a gel or even pre-thickened products as demonstrated on the bottom right. I'm not promoting any of these products. These are just a sampling. Thickeners are used in an effort to make things thicker, most usually liquids. Liquids are hard to swallow because they move fast. So you add a thickener to it, and then it slows the transit so that the muscles and the nerves can respond a little more timely and allow to catch up with the liquid that's moving through. The concern is that people don't necessarily like thickeners. They may not be well tolerated by the lungs if they're aspirated. And finally, it could potentially then limit overall liquid intake, which lends itself to dehydration, which can create other medical problems. So discuss these with your healthcare team. What is a swallowing test? Many times people will have a swallowing x-ray. It's not mandatory, but you may have it. There are a few important points here. A swallowing x-ray is a video x-ray with a camera in front or off to the side of you. This is different than the picture at the bottom of the screen, which is a fiber optic flexible nasoendoscope. That's a flexible tube that's placed through the nose to the back of the nose at the top of the throat. the video fluoroscopic swallowing study, the video x-ray, is generally preferred in this situation because I, as a clinician, get a better view of all of the movements and all of the components that are interfering with swallowing. The flexible nasoendoscope, especially if someone's having trouble with positioning or other movements, can make it difficult to really document and observe what are some of the problem areas. The point of the swallowing test is threefold, as you see here. One, document present level of function. What's working, what's not. Second is there a potential or not for aspiration? And third is to develop a treatment program on how to address the deficits, whether it's weakness, whether it's just things are accumulating, whether things are actually going down the wrong way. I encourage everybody who's having a swallowing test to bring 1 or 2 food items with you. During the swallowing test, they have a variety of items of consistencies and textures. They are all coated with barium, which is the white stuff. It doesn't taste bad, but some of those items may not be things you're having trouble with. So bring 1 or 2 food items that seem to be problematic for you. A bagel with cream cheese, a protein bar. I had somebody who had complaints about nuts and shrimp. So I had them bring those things in. Bring those food items with you so you can be tested with the items that are most problematic for you. When should you consider having a swallowing test? It's highly variable person to person, but if it seems as if you're not responding to the swallowing strategies that have been developed, if there's some indication that there are a number of different problems going on and it's your clinician's judgment to that effect, and particularly if you are pursuing Botox injections, botulinum toxin, if you're pursuing these injections for any dystonia, drooling, difficulty managing secretions, then a baseline swallowing study should be completed prior to the Botox, especially if it's Botox to the jaw, the tongue, the throat, or the neck. Should you try swallowing therapy? My first response is always going to be yes. It's worth pursuing initially just to investigate stimulability. I'm always looking for, can you affect a change? Consult your speech pathologist about this. We're looking to tailor the program to your strengths and weaknesses. Swallowing therapy really breaks down into 2 specific categories. One are compensatory strategies, such as the postural modifications I mentioned earlier, switching out utensils, using different cups, trying different temperatures. That's the sensory enhancements, different temperatures, different textures. It's all about what works for you, what gets in the way and what seems to be helping you, and defining that. And then the second component are direct swallowing exercises, essentially physical therapy for your swallowing to strengthen muscles, to improve timing, coordination, airway protection, endurance, things such as that. I wanted to highlight something specific to cough. There are devices called respiratory muscle strength trainers, RMST. I have one here with me today, a blue one. They come in devices. These are devices that have valves within them that create resistance, and the resistance is graded. You can adjust it to more or less resistance. This is different than an incentive spirometer, such as what you get in the hospital. Those don't have resistance, so they don't really provide work. The whole point of these is to provide work, to get your lung muscles to do work, to your throat muscles to do work. Studies have been done to show that these have been of benefit to swallowing as well as cough. Cough is incredibly important to make the vocal folds work, as well as to keep the lungs clear of anything that doesn't belong there. This one is an EMST 150. The picture on the screen, the green one, is an EMST 75. There's a breather also, that's a different one. These are available over the counter online, but you really should get medical clearance first, as well as guidance from your speech pathologist. It just does this. Just took a breath in and I pushed really hard with my breath. There's a specific protocol to follow for each device. So how do you find a speech pathologist? You're looking for somebody such as myself who's licensed in their state, as well as certified by the American Speech Language Hearing Association. You're looking for someone who has experience with neurological disorders, neurodegenerative diseases, Parkinson's disease. They may not have experience with atypical Parkinsonism, such as MSA, PSP, CBS, things as such, but they don't have to. You can use the ASHA Pro Search site. Any clinician that's who works in a movement disorder center or is a member of the International Parkinson and Movement Disorder Society, who works at a Cure PSP center of care. Also ask your neurologist. You can reach out to me as well. My contact information is here. On the right of the screen is a QR code, and that's a copy of the slides. You're welcome to download those for yourself. Thank you so much for your time. I'm really grateful. Best wishes to you all.
So my name is Mitchell Miglis. I am a neurologist at Stanford University in the Division of Autonomic Disorders and Sleep Medicine. These are my disclosures. None are relevant to this discussion. I am on the advisory board of the MSA Coalition. However, this is an unfunded position. So, overview of sleep disorders in MSA. As many of you probably know already, almost every patient with MSA has some form of sleep disorder. Sleep disorders are incredibly common in these neurodegenerative disorders, in all neurodegenerative disorders, but especially in those of alpha-synuclein deposition, of which MSA is one. And compared to Parkinson's disease, a more commonly recognized and a more common disorder of alpha-synuclein, MSA patients have, in general, more sleep disorders than patients with Parkinson's, at least 77% of patients in some studies versus 51% of patients do have a sleep disorder. And sleep disorder can be any form of sleep problem. In fact, most patients have several sleep disorders, and they can be any diagnosable sleep disorder, including insomnia, sleep disorder breathing, such as sleep apnea, RBD, which stands for REM behavior disorder, restless leg syndrome, or RLS, and problems with circadian rhythms. And we'll get into the specifics of each one of these. And so again, these are the conditions that we are discussing in general that cause many sleep disorders, the alpha-synucleinopathies. MSA is one form of an alpha-synucleinopathy. And it is characterized by deposition of this protein alpha-synuclein. In MSA, it primarily involves the central nervous system, the brain, and parts of the brainstem. And this is important because the sleep disorders that typically result from MSA are the result of this protein depositing in certain areas of the brainstem and the brain, which cause disruption of certain neurological pathways that influence sleep. And so the first disorder we'll discuss, which is incredibly common in MSA, is called REM sleep behavior disorder, or it's abbreviated RBD. And so RBD is characterized by acting out your dreams. So when we dream, we can have vivid imagery, but evolutionarily, the brain has designed a system where we should not be moving during dreaming. And in fact, the muscles in most of our body are paralyzed, so we don't act out the dream, so we don't punch or kick or jump out of bed. But because of where that synuclein protein is deposited in parts of the brain stem, it disrupts that pathway. So the muscles are disinhibited, or patients are suddenly able to move during their dreams. And there can be quite violent movements. Here is an example of a patient here having an episode. There can be punching, kicking, flailing. Often these are direct enactments of the dream that the patient is having. And so you can see there's semi-purposeful behavior, sort of reaching and kicking, but it's not like sleepwalking. You know, patients don't get up, walk around, open cabinets. They don't usually leave the bed. And patients can jump out of bed if they're having a violent dream, but they don't get farther than the floor, right? So if someone is sleepwalking, that's different from something like this, where they're in the bed and typically doing violent activities. If you ask somebody, what were you dreaming about, they can often tell you. And the patient's eyes are typically closed and they don't talk back. And this is different from sleepwalking, where eyes can be open or semi-open and patients can respond to questions. Interestingly, it's much more common in men than women. We don't know why this is. It could be that men have more violent dreams. Could be that women who are caregivers are more likely to report this than vice versa with men. Another important characteristic is that because this is happening during dream sleep, the events are much more likely to happen in the second half of the night. So middle of the night, early morning, because that's when we have more REM sleep. And I'll show you an example slide that explains that in the next slide. And it's important to realize that generally, RBD is very common, affects about 1% of the population. In MSA, it's about 100% of patients with MSA. So almost every patient with MSA has RBD. And I want to bring your attention to the bottom graph on this slide. This just shows different sleep stages throughout the night. And the bars in red at the top here, these are the REM or dream episodes. And we can see as the night progresses, these episodes become progressively longer, and there's more of them in the second half of the night or the early morning. That's why most of us remember our dreams more in the early morning after we wake up out of a dream. So if somebody's having sleep-related movements at night, we always ask, is it happening more in the first half or the second half of the night / early morning? If it's second half early morning, more likely to be a REM phenomenon. So again, very common, about 100% of patients with MSA have RBD. This tends to occur later in the disease, as opposed to Parkinson's disease, where it may be one of the earliest manifestations of the disease, occurring decades before someone might develop movement abnormalities. In MSA, we think that it manifests as the disease is, at least in the moderate stages of progression. Again, there's a broad range of motor manifestations, but usually they're violent. Sometimes it can just be limited to talking, yelling, or vocalizations. Again, walking is rare. That's sleepwalking. That's a different disorder. And it's always important to recognize this condition because there's a very high rate of injury. 60% of patients have reported an injury to themselves, and 20% or more to the bed partner. So the first thing we always want to go through with patients that have RBD is your bedroom safe? So you want to make sure that your bed is not very high from the floor, that you don't have a hardwood floor directly, under your bed that you could fall onto. Patients have fractured bones, broken hips. You don't want to have any sharp bedstand that you can jump into. Facial fractures or lacerations are fairly common. You definitely don't want to have a window next to your bed. You don't want to have any weapons, basically any sharp objects next to your bed. And if the events are frequent and violent, it is best if the bed partner sleeps in a different bed. If you do decide to continue sleeping in the same bed, you do want to have some kind of barrier between the patient and the bed partner, such as a soft, large body pillow to prevent injury. And this is a very good question, to ask. We ask patients this, or to ask yourselves: Have you ever been told or suspected yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running movements, etc. And diagnosing RBD is very difficult without discussing this with the other person in the bed, because self-awareness is quite limited with this condition. Many times when we're dreaming, we fall back asleep. We don't remember the dream or what we were doing. So you really need the history of the spouse, the partner, that has actually witnessed these episodes. So how do we treat RBD? Well, first we discussed safety. That's the priority. Melatonin is the first-line treatment. Very little side effects. It's actually fairly effective. I would say around and up to 50% we're able to control the RBD just with melatonin alone. Usually start at a dose of 3 milligrams and go to a max of 12 milligrams 30 minutes before bedtime. Melatonin in the US is not FDA regulated. It's a supplement, so we don't know the exact concentration in the supplements. There are various brands that might be better than others. Sundown is one brand that we recommend. Nature's Own is a decent brand as well. And usually I would start with 3 milligrams and then go up by 3 milligrams at a time if patients continue to act out to a max of 12 milligrams. At that point, if someone is still having episodes, depending on how violent they are, if they're just talking and really not any major risk of injury, then that's okay. But if there is risk of injury, then we'll think of adding in clonazepam at a very low dose, 0.25 milligrams. And often we'll add that to the melatonin dose. Clonazepam, I have to be careful because it is a sedative. It's a benzodiazepine, and it can have cognitive side effects. It can cause increased risk of falls. So we just have to be really careful using it. However, it is fairly effective for this, and we do use it in a fair number of patients if necessary. So the next disorder that's also extremely common is insomnia. I mean, insomnia is just generally common in the U.S. population and in the world population, global population. And we define this as difficulty falling asleep, difficulty staying asleep, or waking up earlier than you want to, with daytime consequences. So that's usually fatigue or trouble concentrating. And it has to be occurring frequently, at least 3 times a week for several months. And there are different models to sort of understand insomnia, because insomnia is usually not a simple condition to unpack. There's usually many factors involved. It's a multifactorial disorder. So there's a model, and this model has been employed in different facets of neuropsychology called the 3P model. So there's predisposing factors, there are precipitating factors, and there are perpetuating factors. So example of a predisposing factor might be genetics. And we know insomnia is more common in women than in men, tends to run in families, tends to be more common in patients who are more worriers or have some history of anxiety. And then maybe there's a precipitating factor, a diagnosis of MSA, for instance, that really increases anxiety. That's a natural response. And then maybe there's maladaptive behaviors with sleep. Someone's not able to sleep as well. And then because of that, they start doing things that perpetuate the condition. They start worrying about the sleep, or they start spending more time in bed trying to sleep when they can't. And then that kind of reinforces this circular pattern. So the treatment for insomnia, if you do have insomnia, you really want to try to find a sleep psychologist who does what we call cognitive behavioral therapy for insomnia, or CBTI, because medications are a short-term solution. It's not sustainable long-term, especially in MSA. Almost all sleep medications are going to have daytime side effects or increased risk of falls. So cognitive behavioral therapy is a standardized, researched and validated technique and protocol that involves different cognitive techniques to help relaxation, to kind of focus on sleep environment, biofeedback. And typically this is done in 6 to 8 sessions with a sleep therapist, usually 1 session per month. The difficulty sometimes is finding a sleep therapist who does this. This is not a very lucrative profession, and it's quite difficult. So, there may be some challenge in finding someone who does it, but guaranteed in your area, you do have somebody. And I'm just including this website. You can search. This is one of several websites that lists different CBTI providers. If you have a sleep clinic, I would start there and ask the sleep doctor if they have someone who does this in their clinic, or ask your primary care doctor, because they might have private psychologists in the community who also do sleep psychology, CBTI. If you want to start with a reference on your own, here's a good book that I always recommend to our patients, Quiet Your Mind and Get to Sleep. You can find this on Amazon. It's cheap. It's a workbook that was written by some of our therapists years back, and many patients find it helpful. So when discussing insomnia, it's always important to understand what a circadian rhythm is, because this does influence our tendencies towards sleep and wakefulness. And a circadian rhythm is a 24-hour cycle or clock that's actually intrinsic to most animals, and it's actually in almost every cell of our body. We have 24-hour cycles that influence optimal performance of different aspects of our physiology. So most patients that are on a daytime schedule are going to have a peak of alertness a few hours after they wake up, and then there's going to be a dip, during the day, and then the early afternoon there's going to be a period of sleepiness, and then there's going to be another peak in alertness closer to dinner, and then sleepiness again, and that will influence the sleepiness that will induce your nocturnal sleep. And the circadian rhythm is really influenced by sunlight. So in degenerative disorders, including MSA, because of where the protein is deposited in the brain, the circadian rhythm can get disrupted. And we always try to emphasize sun exposure close to the wake-up time. So when your brain sees the light influences when your 24-hour clock starts. So you always really want to wake up around the same time every day. If you vary that, try not to vary it more than an hour. And when you do wake up, try to get a good maybe 20 or 30 minutes of sunlight coming through the windows. Just open the blinds. If you can go outside, that's even better. And if you can walk or do some form of exercise, that's even better still. And these we call these time givers. These are the things that sort of reinforce a 24-hour pattern in our bodies. Sunlight is the most powerful one. So that's why, again, trying to get natural light around the same time every morning. But also exercise. So exercise, if you do that earlier in the day, that's going to reinforce a daytime pattern. If you're exercising close to bedtime, that's going to reinforce a nocturnal pattern. It might make it more difficult for you to fall asleep. Meals are the same thing. So you want to have your dinner, for example, at least 3 hours before you go to bed, because if you're eating right close to your bedtime, then your body's going to associate that with wakefulness, and it's going to be harder to fall asleep. Also, you need some time to digest, and the digestive function can be impaired in MSA, so you want to allow plenty of time for that. So it's really important to think about this. It's not something that is really discussed in most doctors' visits, but if you're having insomnia, think about your sleep pattern. You want to try and reinforce a consistent sleep pattern, get light when you wake up, do the exercise earlier in the day, and try to avoid any of these things closer in the evening that can make it more difficult for you to fall asleep. Light in the evening is a big problem, in the modern world. You really don't want to have a lot of electronics on. I would say, shut all those off at least 30 minutes before bed. Do something relaxing, maybe read a book, listen to a podcast or music, but you really want to avoid that electronic light that can kind of prolong your bedtime. So then another disorder that's very common in MSA is restless leg syndrome. And we use this mnemonic urge to help remember the symptoms. So restless legs syndrome, or RLS, is defined by an unpleasant sensation. That sensation can be many different things, but it has to be unpleasant. It's characterized by an internal urge to move. You feel like you need to move your legs, right? It's worse if you rest, and it's better with movement. And it's worse in the evening. So again, it has a circadian component. So you can have it during the day, but it should be much worse in the evening. And a good question, again, that gets at all the features of restless legs is, when you try to relax in the evening or sleep at night, do you ever have an unpleasant, restless feeling in your legs that can be relieved by walking or movement? If the answer is yes, you likely have restless legs syndrome. And this happens or occurs in at least 28% of patients by some studies. So a very common misunderstanding is RLS happens when you sleep, that I kick my legs, therefore I have RLS. So leg movements during sleep is not RLS. This is a different phenomenon. We call it periodic limb movements. It's not necessarily meaningful clinically. It's not necessarily associated with symptoms or sleep disruption. Restless legs is a feeling that keeps you from falling asleep. It doesn't wake you up. It can keep you from getting back to sleep, but it's not something that happens while you're sleeping. It happens when you're awake. So therefore, you don't need a sleep study to diagnose restless legs. It's strictly a clinical diagnosis based on your symptoms. A lot of patients say, I have restless legs, was diagnosed by a sleep study. That's periodic limb movements, not necessarily something you need to worry about. So a lot of medications exacerbate RLS, many medications. So sometimes it's not possible to stop some of these, but it's always good to go through a list. And if you're having these symptoms, to see if you can change some of these medications. All of those things that I mentioned, those time givers that stimulate wakefulness and circadian rhythm, can also make restless legs worse. So exercise in the evening, meals close to bedtime, alcohol, caffeine, and nicotine. So if someone has RLS, we always want to check ferritin levels. So it's a very simple test, blood test. It's a measure of iron storage. And if the ferritin is less than 60, we treat first with iron sulfate with vitamin C. So you want to take vitamin C with the iron because it helps increase the absorption of the iron, and then recheck the ferritin 3 months later. In some patients who are really iron deficient, we could sometimes use IV iron, which can be quite useful, but it's sometimes difficult to arrange and to get insurance coverage, etc. So then if we decide to treat with medications, there are many different ones. The most common, and I think the safest, would be gabapentin with the least side effects. And then after that, we consider what are called dopamine agonists, which are also used for Parkinsonian symptoms. And these would be pramipexole and rotigotine. There's also rotigotine patch, which is quite effective. Then there are some as-needed medications. Many of these are opiate or opiate-like. Again, these are not ideal in MSA. Benzodiazepines, like we discussed, are not ideal in MSA. But some patients will still use them because the symptoms are so severe, but that's really a last resort. If you are taking a dopamine agonist, like pramipexole, ropinirole, you should be aware of something that's called augmentation. So as you go up on the dose of these medications, as you're increasing dopamine levels, you can start to cause restless symptoms earlier and earlier in the evening, and sometimes they can occur in the day, during the day. And it's fairly common. I mean, 10% almost per year, patients taking these medications will develop augmentation. So if this happens, what we want to do is we want to think about a different medication. You want to get off of that medication or lower the dose and think about using something else. So what will often happen, patients will see a primary care doctor first. Primary care will prescribe these sort of medications, which are the sort of old school classic meds for RLS. And as the symptoms get worse, the doctors will just increase the dose until it starts causing augmentation and making the restless legs worse. And then, maybe they'll be referred to a sleep clinic at that point. And then we'll really try to get patients off of those medications. So if you are taking one of these drugs, just be aware you want to keep that dose as low as possible. And then the final primary sleep disorder that we'll discuss is sleep disordered breathing. So I say sleep disordered breathing and not just obstructive sleep apnea, because patients with MSA can have both obstructive and central sleep apnea, which we'll talk about. Obstructive sleep apnea is like it sounds. It's due to an obstruction, typically from the tongue or the muscles in the back of the throat relaxing when you fall asleep. And MSA itself probably increases the risk of this due to the protein deposition in parts of the brain that control breathing. Central sleep apnea, there is no physical obstruction. It's just the brain does not send the signal in time to breathe. So there's not a drive to breathe. And then again, this is from the protein deposition in the brain and the brainstem. And a third breathing disorder that's fairly common in MSA, is fairly unique to MSA, is called stridor. And stridor, if you hear it, it's not something that you can ignore. So it's a very high-pitched, harsh breathing sound, and it's due to inability of the vocal cords to relax during sleep. And I'll play an example sound here. So if you hear that, it's hard to forget, and most partners will report this. And it's important to report this because it's probably associated with a worse prognosis, and it is treatable. So if there are symptoms associated with these forms of sleep disorder breathing, they can include, of course, nonspecific symptoms like sleepiness, more specific symptoms like snoring or the sound of stridor. It can cause frequent awakenings throughout the night. Of course, if there is an obstruction or an apnea, there can be a pause in breathing followed by gasping or choking. Some more subtle symptoms could be dry mouth in the morning, which would suggest mouth breathing, sometimes headaches or nausea in the morning, and of course, unrefreshing sleep, which many patients have with MSA in general. And it's important to diagnose sleep disorder breathing because it's very treatable. It's the most treatable sleep disorder. And we typically treat it with some form of a PAP, a positive airway pressure machine. And typically this is CPAP. Bilevel or BiPAP is used in some patients. It's not necessary for everybody, but if there is severe sleep apnea, we'll tend to use a BiPAP because we can go higher on the pressures than you can with a CPAP and still keep it comfortable. If there's central sleep apnea, a CPAP alone is probably not effective enough. You need something with a backup rate, so something that stimulates the breathing if there is a central pause. So that can be something called either a bilevel ST or an ASV machine. All of these machines look the same, by the way. They all look like your standard CPAP machine. It's just the mechanics of the breathing apparatus is different inside the machine. For stridor, CPAP or bilevel might be enough, but some patients might require tracheostomy if they're having stridor during the day. And every patient that has stridor should see an ENT doctor to look at the vocal cords, just to also make sure that there's no physical mass that's causing the stridor. And we usually have patients follow with ENT for repeat scoping, just to look at the vocal cords at least once a year. And so finally, if you have problems with sleep, when should you talk to your doctor about a sleep study? Well, there are really a couple reasons we do a sleep study. You don't need a sleep study for insomnia. You don't need a sleep study for restless legs, like we talked about, because those are things that keep you from sleeping. A sleep study is important if there's any form of breathing problem, sleep apnea, stridor, or if there are nocturnal episodes that suggest RBD. And those are the reasons we use a sleep study to diagnose these conditions. And then sometimes we'll do a sleep study to evaluate different treatments. So specifically CPAP, BiPAP, or ASV. We'll often bring patients back for a second sleep study to try out different pressures and different modalities, just to determine which is ideal to treat the sleep disorder breathing, because as mentioned, patients with MSA don't always have straightforward obstructive sleep apnea. They can have some combination of obstructive and central. And to treat that effectively, you really need to do an attended sleep study evaluating these different pressures throughout the night. And I thank you for your attention, and I look forward to answering any questions.
We've had an incredibly insightful and informative session today, delving into the complexities of handling multiple system atrophy symptoms, including neurogenic orthostatic hypotension, dysphagia, and sleeping issues. We sincerely thank our speakers, Dr. Italo Biagioni, Laura Purcell-Verdun, and Dr. Mitchell Miglis for sharing their expertise and helping us to understand these challenging multiple system atrophy symptoms. As we bring this session to a close, I want to emphasize that our commitment to supporting you on this journey extends beyond these presentations. In our comprehensive conference resource guide, you will find a wealth of information covering various topics related to MSA symptoms, treatments, and coping strategies. Whether seeking insight into mobility challenges, cognitive issues, or other facets of living with MSA, the resource guide is a valuable tool to help you navigate the complexities of multiple system atrophy and enhance the quality of life for patients and care partners. But our engagement today does not end here. Immediately following this session, we invite you to participate in a live question and answer session. This session lets you engage directly with our experts, seek clarification, share your experiences, and foster community. Your active participation is welcome and vital in building a supportive network where we learn from one another. Thank you for being part of this critical conversation today. Let's now transition seamlessly into the live Q&A session where we can continue to share knowledge, experiences, and support. Thank you.